with Shubin, how you have called him the master of the bypasses, or the champion.
World champion.
Yeah. So he will talk about the bypass fluid mechanics principles. Okay.
Okay. Okay. Thank you. Thank you, Hugo. We anticipate to listen your presentation next week. So my topic is bypass related to fluid mechanical principles. So for the successful treatment, we should bypass treatment for aneurysms or for moyamoyas. We should know the fluid mechanic principles. The first one is the Bosois Law. So Bosois Law, Q, this is a Bosois Law. Delta P, we can see pi is this pi is pi. It's a fixed number. This is a diameter of the vessel, and this is a delta P. And we can see in this Bosois Law, delta P is the only motive power for driving the blood flow. So we should make sure to keep the delta P positive. Sometimes the stoma near the high pressure location, especially near the Willis circle, it's dangerous for delayed occlusion of the bypass. So we should select the right position of the recipient artery. Actually, in the moya vasculopathy, there's two kinds of pressure gradient of MCA. This is the first type of the pressure gradient of MCA. Still keeps the physiological direction. So this we can see the MCA network will still shoot from proximal to distal. So this pressure is proximal larger than P distal. But there's another pressure gradient of MCA. Yeah, this is a reversed physiological direction. We can see the MCA was already occluded. The PCOM to PCA was quite large. Then from the PCA to MCA, we can see the M2 was the latest shoot in this angiogram. So this P proximal is less than P distal. So after the bypass, we can see in the flow 800, we can see the red T. So red T means bidirection fast blood flow. It also means a big difference of delta P. So this kind of bypass is sustainable. This is a single bypass in the left picture, and this on the right, it's a double bypass. But sometimes we can see this is a one short arm of red T. We can see the pressure balance point is located in this side. It's only, so this delta P is barely positive. It's only maybe less than 5 millimeters. So just after 1 week in the CTA, we can see the bypass was almost occluded because the delta P is too small. We can see the balance point located just very close to the stoma. So we studied we compared the two pressure gradient of MCA and the bypass direction. So the first in the first pressure gradient of MCA, we the pressure of the proximal is larger than the P distal. This is the second way. And this is the first, if the main blood flow, if the main blood flow flowing in the recipient artery, it's from the higher pressure zone to the low pressure zone. This is we call it the parallel bypass. If it's from the low pressure zone to the high pressure zone, we call it anti-parallel bypass. So this is a result. The conclusion is parallel bypass is better, which means the bypass from the main flow from the bypass to the recipient artery. It's a parallel of the pressure gradients is better. The second common fluid mechanical principles is the Ponoris Principle. This is a Ponoris Principle. It's mainly about the blood flow energy loss. In the Moya, we can see it's we called it a slot principle. So the flow, this is a Moya syndrome. We can see from the distal part of ICA originated from some Moya vessels, then from the Moya vessels to the M2 segment. So the flow velocity is the largest at the contrasted section, and the increase in flow velocity is accompanied by significant decrease in pressure at the constricted section. So this is a model of the in the lowest picture. We can see this is a fluid mechanicals. So the M1 bloodstream flow through the Moya vessels, then into M2. It's similar to the flow through the restrictor when the beam expanded into a larger area to M2 segment. And then the velocity decreased, pressure increased, but the downstream pressure doesn't fully recover to the upstream M1 pressure due to the greater internal turbulence and the energy consumption. So this is what happened in the Moya vessels. So this is the energy loss. We also can calculate with the different shape of the stoma. So this is a relationship among the diameters, the perimeter, and the cross-section area of fish mouth anastomosis. Because a lot of neurosurgeons, they recommended this fish mouth stoma technique. But we can calculate the resistant coefficient zeta. So this is a calculation of the zeta of the stoma, this fish mouth stoma. We can see in the fish mouth stoma, this is a D3, actually it's D3 equal to the D1 to D2. So this is a zeta. This is the greater the ratio of A3 to A1. A3 means this section area to the donor artery A1. So this ratio, the greater the ratio of A3 comparing to A1, the greater the resistant coefficient is. The resistant coefficient zeta is proportional to the square of A3 to A1. So this is an example for bigger ampular part of ICA. This bigger part actually causes additional local energy loss. When the blood flow into the common blood flow come from CCA to ICA, through the anterior part of the ICA, the blood flow will separated and form a shear layer. This is the blue part, and the shear layer will flow unsteadily and result in irreversible local energy loss. So this is what happened in the fish mouth stoma. The stoma, in my opinion, the stoma should keep oval shape as natural branches. We can see the natural branch shape. It's all oval shape. So our stoma should mimic the natural branches. So this is a relationship among diameter, perimeter, and the cross-section area of ovoid and anastomosis. We can see this is the calculation of the zeta in oval shape anastomosis. So under the same conditions, the ratio of A3 to A1 is closer to 1. So the local resistant coefficient zeta is smaller comparing to fish mouth, and the local energy consumption is lower. It's much lower. So this means it's a better shape of the stoma. Actually, the local energy consumption is quite dangerous because, you know, in the aneurysm, it's also because of the local energy consumption, the aneurysm was can getting bigger and bigger, it can growth and rupture. So this is the oval shape stoma's normal sequence of the stitches. And after the first stitch at toe, there's a last chance to trim the stoma to make it in the same size. You can see the total artery and the recipient artery, the stoma shape was all ovoid. The first stitch is to the toe, then the heel. The square knot is enough. The suture tail should point to the different direction of the two knots. So this can make the square knot. So you can see in less than 6 minutes, the stoma was finished. So all the recipient, the branch of the recipient artery was protected very well. I never sacrificed any recipient, any branch of the recipient artery. So sometimes we can use some small perforator to let some small reflux of the blood flow. This can keep a little bit the pressure in the recipient artery to make the two layers of the recipient artery open. And this can help us in the anastomosing. with the red color of the blood, we can see the recipient artery and the vessel wall, both of the donor and the recipient artery very clearly. And sometimes, especially in the STA, we can see some sharp bands. It's very common, and we can suppose the STA is taken from point to A to point B. If the connective tissue is cut in the sharp band, to make it more straight. On the one hand, the local energy loss Hj of the band can be reduced. On the other hand, the flow can be shortened and the HF reduced. So if you cut the connective tissue at the sharp band and make the vessel more straight, actually you reduce the angle theta and increase the rate to D. Actually, this kind of solution can reduce the secondary law and make the blood flow energy loss much less. So this is you can feed the recipient artery with more blood flow. Sometimes, actually, especially the donor artery is much bigger than the recipient artery, so we have some bottleneck of the blood flow. So this is the first way to make the less wasteful of the donor flow. So when the ratio of donor diameter to the recipient diameter is greater than 1.2, so the draining capacity of the recipient vessel is less than the maximum blood flow provided by the donor vessel. Normally, it's cut flow. So Q1 actually can it's equal to the sum of Q2 to Q3 to Q4. So Q4 is the increased part, so which is equivalent to the opening another hole in the restrictor, and will reduce energy waste of the donor vessel. So I prefer to use the stoma located along near the bifurcation of the recipient artery. So this can make the recipient artery drain the blood flow more efficiently, like this way. So the bottleneck of the blood flow, how to be less wasteful, the second way is use double barrel bypass with only single branch of STA. Normally I use a parietal branch. So at the first, I preserve the frontal STA branch, then cut one of the maybe 2 or 3 centimeters from the long segment, then to make another end to side to the branch of the recipient, to another branch of the recipient artery. And so this can make the donor artery's blood flow even more. So this is a targeted bypass, should located in the low pressure zone. So this is a single bypass, double bypass, even triple bypass. For double barrel or triple barrel bypass, normally one stoma in the superior trunk territory, one in the inferior trunk territory of MCA. So this is a long-term follow-up. After 7 years bypass, we can see the STA becomes so big, and the blood flow actually not only feeded the whole hemisphere, but also the contralateral frontal lobe. So this is after the revascularization of the whole hemisphere, we can see almost all the hemisphere, almost all the brain was fed by the ECA branches. The three layers, middle meningeal artery, STA, deep temporal artery, was all feeding the hemisphere. So this is a blood volume change in Moyamoya disease. We can see that bypass, middle meningeal artery, deep temporal artery, and the STA was all increased. In the ICA or basilar artery was all decreased. So this is why we can decrease the hemorrhage rate in the ICA Moyamoya vessels and the posterior circulation Moyamoya vessels. So this is my take-home message. Understanding the fluid mechanical principle is key to successful bypass surgery. Bosois Law, Ponoris Principle, and the throat principle is very important in bypass surgery. And especially in the Moyamoya vasculopathy, there's two types of MCA pressure gradient. So the parallel bypass is better than the antiparallel bypass. Fluid mechanical formula for calculating the resistant coefficient zeta of different stomas shows that the ovoid stoma is better than the fish mouth stoma. And we can make the bypass more efficient if we choose the right position of the recipient artery with more bifurcations. Actually, it can be drain more blood flow into the brain. Okay, thank you.
Okay. Good, Hugo?
Yeah. Bin, that was a great talk. I'm very interested in a little bit complex to understand too.
Yeah.
Yeah,
it's
but
quite complex.
all the principles are important, so then you can guarantee a patent bypass.
Yeah.
Yeah. I don't know if somebody else wants to add something to Bin. Nope. How much is the bypass count now? 7,000?
Yes, 7,000.
Good.
Bin, how, Professor Bin, in your experience, how many cases have long-term restenosis of bypass in your experience?
You mean long-term follow-up, in the long-term follow-up, the stenosis of STA bypass? Yes, some actually, especially in the early stage of the bypass, there's two kinds of conditions. One is between the different branches of ECA, then competition between the STA with and other donor arteries like middle meningeal artery and the deep temporal artery. Actually, I always use a combined approach in treat the Moyamoya vessels. So in the long-term follow-up, actually, if the middle meningeal artery and deep temporal artery already formed the spontaneous stomas with the cortex, and sometimes this kind of stoma is even more efficient than the STA. So, and it's also changed the pressure gradient of the cortex. So this kind of competition can cause the STA stenosis. This is the first stenosis condition. And the second one is in some complex aneurysm treatment. sometimes because of the ACAM and PCAM, it also can enlarge after maybe several months. So this is also have some competition with the bypass vessels. So sometimes at the just after the surgery, the STA or some bypass vessel is quite large, enlarged a lot. But after several months, if after the ACAM or PCAM, the blood flow get more and more blood flow from the ACAM and PCAM, so the bypass can be get smaller. So this is a second condition. Because there's always competitions between the same side ECA, different branches, and also some competition between the ACAM and the PCAM vessels.
Good, thank you very much.
Mm-hmm.
Okay, very good. If there's no more questions, we'll move on to the next presentation.